repeatable error or errors, plural, that you can see? Jay?
Clipped anatomy.
Clipped anatomy. Which anatomy is clipped?
Spinous process and some of the pedicles, lamina.
So we do have quite a bit of clipped anatomy, but what else is wrong? Like what caused the clipped anatomy? Clipped anatomy. Very bad centering, right? Well,
Maybe rotation in the hips.
actually, we say bad centering, but when we look closer, this is pretty centered.
Yeah.
Now we could probably center a little bit lower the central ray, but this is pretty straight. But then all of a sudden, what's going on here?
It's not as
Patience.
What likely happens here?
their shoulders aren't in the same plane as their hips.
It's probably something to do with the upper torso. The patient's curving backwards. They're not sitting on it. They're not in a nice straight lateral table, which is why I tell you to do that walk around, check the shoulders and the hips, make sure they're in the same plane. Otherwise, you get something like this where the patient's back's curving backwards, and then we end up clipping anatomy on the posterior surface there. What else? Anything else you can see?
Are the hips rotated?
The hips are rotated. How can you tell?
I see different lines.
Look closely. Here's a crest. Here's a crest. So we got all kinds of issues going on there. Anything else? Oh, there should be one y'all pointed out immediately.
Oh, the marker.
No markers, no marker at all. We can't send that in without a marker. It's gotta be repeated. So very good.
That would be a left physical.
That would be a left marker, yes. Right here. Let's take a look at this lateral L spine. Now, go ahead and tell me what's going on with that. And you can see it on the TV screens as well. Might be a little easier to see, but what's the most obvious repeatable error, or is it good? It may be a good image I threw in there just for fun.
It's not collimated enough.
It burnt out the top. Oh no, that's the.
It's still
Those are
rotated
the lungs?
because of the hole, the little round things at the bottom of the vertebral body.
That is a good observation. So first thing Shamika said was rotation. She can tell by looking at the foramina. Can y'all see that? Almost like some little teeth coming out of it. We don't have that nice round shape. What else can show us that we got some rotation going on?
Oh, some at the holes at the end.
These right here,
No.
right? The foramina?
At the vertebral body, at the bottoms. Remember you was telling us about the holes?
Yes, that's what I was hoping someone was going to say next.
Big
But
square
I thought you were talking about
hole.
these first, which you can see.
Oh, well, yeah, that-
But yes,
Or you mean the
the
angulation?
disc spaces. The disc spaces. Can you see how it looks like there's these little ovals? They're not that nice straight square shape. That tells us that either the patient's hips and shoulders are rotated, or it's taken at an angle of the tube. Can also cause that. So that's a big no-no. We don't have that nice clear space that we want to see. Does everyone see that, by the way, what I'm talking about? Those little shapes, those little oval shapes, it's kind of closed off. Open down here, by the way, but not so much up here. We also have that same problem slightly as the last image. See how the back starting to curve back here? It's not that nice straight line we want to see. We should also slightly posterior. I'm just taking over. I'm sorry. Y'all need to keep going. What? Anything else wrong? I can tear images up all day. We could probably collimate a little bit more. It's not repeatable per se, but if we want to optimize, yes,
Is it rotate like the iliac crest again, or?
slightly. How about, not necessarily repeatable, but how about our overall centering on the anatomical landmark we're supposed to use? Is that optimal or is that pretty bad? Where are we supposed to center for a lateral L spine?
Iliac crest.
Iliac crest. So where's our iliac crest? Look how far down it is. We need to center a lot lower on this image. So good.
Because normally it doesn't have like, it has like 2, 5.
We got
It has like 2,
11
2.
and 12 on there. Yeah, we don't need all that. So good. Oh, this one right here. Here's a spot film, lateral L5S1. What do y'all think about that? Let's critique that. Is there anything repeatable, or is it good?
The marker's too close to the
I'm glad you said that first, because I want y'all to look closely, because you probably see this a lot in clinic. This marker's in actual anatomy. Can y'all see that?
Mhm.
If your marker's ever actually in anatomy, especially bony anatomy, you should not be sending that image. Optimally, even though we may see it in clinic, optimally, a marker should never be obscuring bony anatomy. You can put it in the tissue, but not in the bones right here. So be careful on that. So yes, that would need to be repeated technically. What else? Might be easier to see on the TV screen what I'm looking for.
Rotation.
rotation, we're almost in a true lateral. Look how close those crests are. Very slight, but not repeatable. What's the main issue aside from that marker? Hmm? Oh, we don't need coccyx because we're doing, look, who's the star of our show?
The angle?
So you need to look at the star of our show.
The
Is it not
angle?
open enough?
Both of you are correct. So angle and not open enough. It's not open because there's no angle on this x-ray. Look closely. You probably need to look at the TV screens. It's a little bit hard to see on here. But this joint space is closed off. That's closed off. We did not utilize the proper angulation on that actual x-ray. Or we didn't use an angle at all, rather. Does everyone see that?
Okay.
Do you see how it's completely closed off? Or do you not see it? So you need to be able to see that.
You see those holes in the bottom of the body? I thought if you see the holes, it's angled.
On this?
No. The S or L4, L4.
These right here?
The bottom hole of the body.
Well, that's also closed off because of the lack of angulation. It all kind of works together on that joint space in particular. The foramen would open up more too with the angle. Good observation though. But I want to make sure, can y'all see it? That's closed off. That's an easy mistake to make if you're not looking closely. Look on the TV screens. It's a lot more HD.
So it's too
That's why I said look at the
bright.
TV screens.
But this is Vita image say the contrast is not so good.
That's pretty normal in the contrast, but you would see a nice, distinct dark space there if that was opened properly. That's one thing to keep in mind. See how, I mean, I'm glad you brought that up. You see how white it is? That's also indicating it's super closed off. Let's look at this oblique L spine with our Scotty dogs. So, is it over or under rotated? How can you tell? See what I did there with the dogs?
Yeah.
Remember you said you were gonna come
The
back
third
to
one.
this, remember?
That's why we're coming back to it.
No.
I speak no lies.
I think it's an over.
So if you're saying it's over rotated, you're correct. But how do we know that? Yeah, look at our eyes, guys. Ideally, the eyes need to be more central on the vertebrae. Now, this one's pretty good, but if you look at these other ones, look how far back each eye is going towards the spinous processes back here. If the eyes are close to the posterior section, that indicates over rotation. Over rotation. I'm going to show you the opposite here in a second.
Under is too far forward.
Yes, yes. You do need to know that. So take a look right here, guys. Now look where the eyes are. Do you see how they're far more anterior compared to the last image? So this indicates that we are what? Under rotated. Under rotated. So let's go back. Over rotation because the eyes are too posterior. Under rotation because the eyes are too anterior. If you look at how much more distorted the dogs are as well, that's something else that can indicate that under rotation as well. Is it making sense? Are we seeing that? Keep in mind, this can reverse the other side if we're doing the other oblique. This is an RPO. If it's an LPO, the eyes are going to be over on this side. You still need to be able to identify that over versus under rotation. I would take pictures of those with your phone so you can take a good close look at those. I don't mind if you take pictures.
This is LPO one.
This is an RPO. This is the side that's down. This is the elongation of the ala.
Can you go back to the last image?
Yes.
Thank you.
So if that was RPO and it's over rotated, that means. That like the left side of their body is too.
Two oblique. Yeah, so it'd be more like a 60 or a 70 degree oblique, something like that. And then under rotation would be like a 20 or 30. You can also look closely, guys, and one great indication for under rotation as well is you look how long the nose is coming out. A little hard to see on this projection, but if you look on the TV, the nose is very long. It's sticking far out. That's a good indication that it's under rotated as well. Making sense? Yes? Let's look at some questions now. Let's see if we can identify some positions based on the questions I'm about to show you. Isn't that a beautiful image? Yes. That's how y'all gonna be on this test on Friday, right? No, y'all gonna do good. Y'all gonna do good. All right, look closely, guys. Identify the projection and the anatomy of interest.
A is an axis.
So apiaxial coccyx. How do we know it's an apiaxial coccyx? Why is it not a sacrum? Well, don't look at the bracket. The bracket kind of gives it away.
Yeah.
But that bracket was not there. How would you know that is a coccyx versus
The
sacrum?
sacrum is cut.
Correct. So apiaxial sacrum, you will not see the coccyx if you did it correctly. But also, you can, if you look closely, you can tell the sacrum is more foreshortened. And look, this is very prominent. See how long the coccyx is? It's very prominent. It's above the pubic symphysis. We can see it free of superposition. Has to be apiaxial coccyx. So the best indication, if you see the coccyx, it's likely a coccyx x-ray. No more complicated than that. So apiaxial coccyx x-ray. What about this one right here? You can really see a difference there now.
Apiaxial sacrum.
So that's the apiaxial sacrum, can you tell?
We have the whole sacrum there.
Look at how much more prominent that sacrum is, guys. Why is it not SI joint? Because they're kind of similar, right? Why is it not B and D?
Well, it's not oblique.
It's not oblique. Now see how I got tricky there? So apiaxial sacrum may look very similar, but that's not an answer choice. I had obliques on there. It's clearly not oblique. It has to be apiaxial sacrum, guys. Sacrum. But back and forth, can you see the difference between the two? Coccyx, sacrum. Coccyx, sacrum. Sacrum, coccyx. Yeah, we got it. Repetition's good. Jay?
And you said you wouldn't include like bilateral SI joints as an answer choice?
If I get you an image like that, no, that'd be a little unfair because they're very close in the way they look.
And you said the only difference was collimation size, or?
Not exactly. It's just it's a very subtle difference, but I wouldn't do that to you. Brett, you wouldn't do that either. They're very similar in the way they look. All right. So what is that? Specifically, what is that?
B's and D's.
Left.
So careful. Look at the wording carefully. It's not saying which oblique it is. It's basically saying what's the star of your show. Look at it closely.
D's and D's.
That's a left. That's D, guys. Apioblique left. Look at the wording. Apioblique left SI joint. But if it was saying what specific oblique is that, what would be the answer?
RPO.
RPO. See how I can get really tricky? Depending on the wording. You gotta read it very carefully. Be careful. By the way, what's the degree of obliquity on that?
25.
25 to 30.
25 to 30. Very good.
25 to 30.
Not 45.
Perpendicular.
Not
Or 30 to
45.
35.
25, 30.
25 to 30 oblique. You're thinking of the angle for the bilateral.
That's, yeah.
Oh, my fault.
All right, guys, what is this?
C's and cat.
Says the.
C as in cat.
Yeah.
I agree too. That is obviously an APL spine, guys. APL spine.
It's not B.
Could not be anything else. What about that one right there? What are we looking at?
A.
Lateral sacrum and coccyx. Lateral sacrum and coccyx. Be careful though, because a lot of people get fooled because it does look very similar to the L5S1. Look at what you're visualizing, guys. If you see that entire sacrum and coccyx on there, that has to be lateral sacrum and coccyx. But if it's cut off, as it should be for an open joint, L5S1, it's gonna be your spot film. How about this one?
That's a D as in dog.
Remember, which side are we visualizing? That's what you gotta know.
So I guess it would be A.
It's definitely not B or C. We can
A.
eliminate those two.
A is an apple.
remember,
Left
the side down. So that's where I said you gotta be careful, because this is where we're mixing things up. SI joints, we're looking at the side up. For the oblique L spine, we're looking at the joint that is down. The joint that is down. I would write myself a little chart, guys. It's very, very easy to mix up. Very tricky. So, let's look at this closer. What specific oblique is this? RPO. And is this correctly rotated? For the most part, it is. And once you look close and look at the eyes, they're extremely central. These look like they might be a little further back, but you base this mainly on the two down here, guys. That's the ones I want you to focus on when it comes to critiquing. I didn't mention that before. Focus on L5 and L4. These are naturally going to move further up as you go up, but they're going to move further back as you go up, but these are the two you want to base that analysis on, guys. These are very central. That's correct rotation. That's 45 degrees. Yes.
Because when I was doing it, the one below L5 is also a Scotty dog.
It is.
So
we don't. We don't look at that one.
But then why? What vertebra is that?
Huh?
What vertebra is that?
You tell me. You should know that.
Below L5. Oh, this is the sacrum.
Correct.
So sacrum also has a Scotty dog.
It does. Very small, but it's there. Yes. But once again, guys, when it comes to image analysis, when it comes to critique, when we're looking at under versus over rotation, I want you to focus on L5 and L4. Does that make sense? Yes?
Yes.
If they were to optimize the image to make like the higher Scotty dog more prominent, would they do 46 or 47 degrees? Just like slightly rotate them more or less?
You're going to always stick to 45. Yeah. All right. What about this right here? Anybody else?
That's
Just
what
Monsi's got it?
The Ferguson.
Yes, it is Ferguson. This apiaxial, the Fergie method. Called the Fergie method. How about that? Now, don't rely upon these nice little labels to kind of help you out as well. But what's the biggest indication that that's the Ferguson, guys? Without me telling you? How do we know for sure it's the apiaxial L5 junction, including SI joints? What are we looking at on that X-ray?
It's racist, it's in the SI joints.
We're looking at the open SI joints, the open L5 as
Oh,
well.
that right there.
That right there, guys. If you remember on our regular AP, that's going to be closed off. But we do this Ferguson method to open that joint up. It's basically like our spot film from an AP view. Yes, we can see the SI joints as well, but that's the biggest indicator right there. Now, if you see like an answer choice like that in there, a PA-axial sacrum, don't worry because we don't actually do those. We know we went over it. It's never going to be your answer. Keep that in mind. It's always better to do the AP-axial. Definitely not oblique. Definitely not coccyx, you can't see it. But another indication why that could not be a sacrum, guys, if you look closely, look, this whole chunk of the sacrum's cut off. Y'all see that?
Is there pubic symphysis slightly dislocated?
It looks like it might be. It's a little crooked.
Comfy.
Might just be the way they're lying, though. All right. How about that one, guys?
D is in dog.
Can't be anything else, right? Has to be letter D, L5S1. Correct. Do we know why it's the only one it can be? Why couldn't it be lateral sacrum?
Because the coccyx cut off.
Half the sacrum's cut off, too. Half the sacrum's cut off. There's no coccyx at all. Can't be that. Definitely not a lateral L spine. Maybe the tiniest L spine I ever saw in my life. All right, there we go. We are at the end of our final section before the wonderful world of head work. But you get a spring break before head work, so that's nice. Yeah. All right, guys. Any questions? Questions?
What did
Your-
you? Sorry, what were you saying?
I was going to say your test will be at minimum 50 questions, multiple choice, usually at 20 to 25 image review questions as well. probably about 20. It's a smaller chapter. Maybe more multiple choice than that, but at minimum 50. So expect anatomy, expect positioning. Make sure you review things like those obliques. What are we looking at per obliques? There'll be a couple of images on there showing you some oblique Scotty dogs. I want you to identify whether it's over or under rotated. Remember, focus on L5 and L4 primarily. Determine that, put it at the pedicle. And make sure you look over those Scotty dogs, guys. I'll say it again. Scotty dog, Scotty dog, Scotty dog. Adopt yourself a Scotty dog. Study on your Scotty dog. Go to the animal shelter and get you a Scotty dog. It's gonna help you out.
Like what the anatomy is, like on the open.
What about?
Like even
Yes, like on a radiograph. Make sure you can identify that. Good question, Shaheen.
So please, would you give us the practice, the answers for the practice?
I'll release those, yes.
Thanks, sir.
Now, because we have a little time left, if y'all would like, I can show y'all that spot film positioning method. Would y'all like to see that, or would y'all rather study?
Are you talking about this one or?
So the special method for the spot film.
Yeah. Sure.